Good morning, everyone. This is Elisa Orona, Executive Director of the Health Improvement Partnership of Santa Cruz County. Welcome to the 2020 HIP Annual Community Forum. Thank you all for joining virtually today as we hear from our event keynote speaker, Dr. Anthony Iton, and as we celebrate the incredible work of our Lifetime Game Changer awardee, Michael Milward. As most of you know, this event has traditionally been held in person. We look forward to the time when it is safe to convene as a community of stakeholders committed to the health and wellness of our county. But in the meantime, I am confident that on today's call, we can recreate virtually the goodwill and optimism for the future that the HIP Annual Forum represents. This is certainly the time when our years of collaboration and partnership will help keep our county's residents healthier and resilient. Today's presentation will fill our collaborative cups and give us insights into the path forward toward a future of health and well-being for all. We know that everyone on this call is experiencing the drastic effects of the COVID-19 pandemic. But we also recognize that being together, even virtually, to reflect on community health, wellness, and equity can be just what the doctor ordered. So our goal today is to bring you perspective, inspiration, and solidarity with and for the healthcare community and the people we serve. We would also like to thank our forum sponsors. Hospital Council of Northern and Central California, Santa Cruz County Bank, and Five Branches University. We appreciate your multiple years of support to the forum. So before we begin, I'd like to make a few announcements about today's event. If you would like simultaneous Spanish interpretation of the event, please call the number displayed on the slide. It has also been sent in the chat box. To ask questions throughout this event, simply click on the Q&A icon at the bottom of your screen and enter your question into the box. Lastly, I encourage you all to enter into the HIP Community Forum raffle, where we will draw winners at the end of the event. The objective of this raffle is to collectively reflect on what each of us would like to commit to doing differently tomorrow and change the odds for someone in our community. As you hear Dr. Iton's keynote speech, think of what you would like to pledge and submit it in the form that has been set up for this event. You can access this form through the link which HIP staff just sent in your chat box. Please submit your pledge by 11:50 to be entered into the drawing. Here are some of the prizes that you could win. One of 2 coffee chats with a local celebrity and a $10 coffee shop gift card. A $50 gift card to Manuel's Mexican restaurant, one of my personal favorites. Or a new patient package at Action Chiropractic. Or an acupuncture therapy session from Five Branches University. If you want to increase your chances of winning these prizes, you can do as Sarah from HIP did, and after submitting your pledge, post your pledge on social media and invite people to join the HIP Virtual Forum. Don't forget to use the hashtag HIPForum2020. Again, please remember to submit your entry by 11:50 a.m. I would now like to introduce our event Master of Ceremonies, Keisha Browder, CEO of United Way of Santa Cruz County. Thank you, Keisha.
Well, good morning, everyone. I want you to know that we are safely social distancing with our fashionable face coverings. And even though we cannot be with you in person, we refuse to allow this day to crush our spirits. So I want you to know we are dressed up as if we were in the ballroom celebrating in the evening. You should see the tuxedos and sequins gowns that are in this room today, socially distancing. So I am thrilled to be here and welcome everyone. As the CEO of Your United Way, I am thrilled to share with you how inspired I am by the ways in which this community is coming together to rally around well-being, to ensure that our young people, our aging population, our families, our friends have access to the quality care that they need in order to move through this current pandemic. As a board member for the Health Improvement Partnership, I must say that I continue to enjoy the ways in which we come together to talk about those needs, to identify the needs in our community and the ways that we rally around and mobilize to support things like health and wellness, making sure that our families and friends have access to food, making sure that those of us who need that emergency financial assistance have the opportunity to do so. So no doubt this pandemic has disrupted systems, but it has not crushed the spirit of Santa Cruz County, the ways in which we come together to say, this is our community, we have the thought leadership, we have the creativity here to innovate, to make sure that we are designing a culture of health that can be shared by all. Today, I have the pleasure of introducing Dr. Anthony Iton. And I start by two questions he asked on one of his TED Talks. Is inequality making us sick? Does your zip code matter more than your genetic code? I am honored to introduce our keynote speaker, Dr. Anthony Iton. Dr. Iton has been an active leader in expanding access to affordable, quality healthcare for underserved individuals and communities. His interest in community health stems from the contributions that race, class, wealth, education, geography, and employment have on our health status. As Senior Vice President for Healthy Communities at the California Endowment, Dr. Iton continues to move forward on his mission to promote fundamental improvements in the health status of all Californians. Prior to his appointment at the California Endowment, Dr. Iton served as the Director and County Health Officer for the Alameda County Public Health Department. Under his leadership, Alameda County launched an innovative plan to improve the health and lifespan of low-income communities by focusing on poverty, racism, and discrimination that prevented residents from getting good housing, that prevented them from getting better jobs, and prevented them from quality health care as well as educational opportunities. Dr. Iton's dedication to improving the quality of people's lives was founded during his contrast experiences growing up in Montreal, Canada, and attending medical school in East Baltimore, Maryland. Dr. Iton, we are thrilled to have you join us in Santa Cruz County today, and we look forward to the insights you will provide on ways we can change the odds. There couldn't be a more important time for us to have you here with us today. We are so aware that this virus is shining the light on the inequities that you will speak to, and we know that this is our moment. This is our moment to recognize that the quality of democracy is a true measure of the quality of health. Dr. Iton, welcome.
Thank you very much. I greatly appreciate that introduction. And I believe I need to now share my screen, so I'm going to do that. And hopefully this will work. And looking good. Okay. There we go. So I need some confirmation from anybody that they can actually see the slide that my slide that's up on the screen.
Yes, Dr. Iton, we can see you. We can see the slides.
Great. Okay, so it's a real pleasure to speak with you today. I really wish it was in person because it's so hard for me to judge, you know, how folks are reacting without seeing faces, and you know, I'm kind of a people person, so I like to be able to sort of assess how people are reacting to what I'm saying. So because we can't make this as interactive as optimally we'd like to, please ask questions, and no question is a bad question. Ask any question, even the obnoxious ones. I enjoy questions. So I'm going to jump right in, unless somebody tells me not to. First of all, I should say that, you know, I entitled this presentation Policy Violence, the Root Cause of Health Inequity. And so I want to make a very clear kind of assertion at the beginning of this, that what we're facing in terms of health inequity is man-made. It's not natural. These are not sort of how societies naturally kind of form and settle out. This is the result of intentional policy neglect in our society, and it can be unmade just as easily as it was made. And you know, I like to say sometimes that it's man-made, and it will most likely be unmade by the work of women, because I think women actually understand how health is connected to all of the other domains of our life better than do men. Sorry, I just think that that's true. Someday I'll prove it. Okay, so I'm a lawyer as well as a doctor. So one of the things I like to do as a lawyer is just state my conclusions up front. And it's something you learn in law school because you oftentimes will be cut off by a judge or not be able to make your full argument. So you want to make sure your conclusions are out there. So you state your conclusions up front, and then you argue back from your conclusions. So one of the conclusions I have is that there's a false paradigm in this country about what health is. And that one of those paradigms is that health is behavioral. It's whether you smoke, it's, you know, how much you drink, what kind of foods you eat, how much you exercise, and it's basically your fault if you're unhealthy because you've done something wrong. Another paradigm is that health is transactional. And what does that mean? Transactional means it's about the frequency and the quality of medical services or medical transactions that determines the quality of your health. In other words, if you have a good doctor, you have good insurance, you have access to technology and, you know, great pharmaceutical creations, then you're likely to be more healthy than somebody who doesn't have as good access to those things. And a third paradigm for thinking about health is that health is genetic. Somehow it's a lottery, and those with good genes are healthy, and those with bad genes are unlucky, and it's just basically the luck of the draw. One thing you'll notice about all of these paradigms or frames is that they're focused at the individual level. They're not focused on communities. They're not focused on our larger society. They're focused on what you as an individual can or can't do, or should or shouldn't do, or were born with, or have access to. And I want to argue to you that all of these frames are wrong. They're weakly accurate, but so weakly that they're essentially ineffectual. Yet we've oriented almost our entire health system around these three frames. trying to change people's behaviors, trying to get them more access to the doctor, and trying to tinker with their genes. I'm going to argue with you, hopefully somebody will argue back, maybe you won't, that health is political. And political there is with a small p intentionally. One definition of politics is it's the struggle over the allocation of scarce and precious social goods. Now, I say small p political because I'm not talking about Democrat, Republican. I'm talking about participation and the quality of our democracy and the ability of people to express their voice and to hold systems accountable locally shapes their health. And if we want to improve health, we have to improve the ability of all people in all communities to participate meaningfully in decision-making that shapes their health. So this definition of politics is the struggle over the allocation of scarce and precious social goods. Notes that this is a struggle. This is not just a Sunday stroll in the park. People have interests, and those interests will be defended. People have to have the power and voice to advocate for their own interests in these debates over how to allocate these goods. I want to note the word scarce in this definition. One of the reasons I'm not completely fond of this definition is I don't like the idea of exaggerating the notion of scarcity. I'm going to get to that in a minute. So if health is political, that means that power matters, both at the individual level and at the community level, and I'm going to get to that as well. Okay, another conclusion is that health is not health care. I think most of the people in this audience know that. Where you live matters, and it matters a lot. And finally, my last conclusion is that health is an investment. It is not an expenditure. Health care is an expenditure. And if we invest too little in promoting health and creating health, we end up expending heavy resources on health care. Okay. Countries that have figured that out have so-called strong social contracts, and I'm going to explain to you what that means, social contract or social compact. And those countries that have stronger social contracts have better health. Okay, that's it for the conclusions. Now I'm just going to provoke you a little bit. I'm going to read this to you, and then I'm going to tell you who said it. I will say that I am not, nor ever have been, in favor of bringing about in any way the social and political equality of the white and black races. That I am not, nor ever have been, in favor of making voters or jurors of Negroes, nor of qualifying them to hold office, nor to intermarry with white people. And I will say in addition to this that there is a physical difference between the white and black races, which I believe will forever forbid two races living together on terms of social and political equality. And inasmuch as they cannot so live, while they do remain together, there must be the position of superior and inferior. And I, as much as any other man, am in favor of having the superior position assigned to the white race. Now, if we were in a room together, I would ask you who said that. Some of you know, many of you probably don't. But that was Abraham Lincoln, the so-called father of emancipation, the great emancipator. Many of us have been to the Lincoln Memorial and have seen the second inaugural address and the Gettysburg Address carved into marble on the walls of the Lincoln Memorial, but we don't see Lincoln's overt white supremacy. And the question for us is why? And what was Lincoln saying? This was in 1858 when he was running for the Senate. What was he saying when he was expressing his white supremacy? He actually went on to say, our Republican system was meant for a homogeneous people. Homogeneous people. As long as blacks continue to live with the whites, they constitute a threat to their national life. Family life may also collapse, and the increase of mixed breed bastards may someday challenge the supremacy of the white man. So I don't know about you, but I think most objective people reading these words would have to conclude that Abraham Lincoln was an avowed white supremacist. And the reason I'm showing you this is because narrative matters. If you want to take home just a handful of things from what I'm saying to you today, take this point home. Narrative shapes policy, policy creates conditions. I'm going to explain what I mean by that in a minute. But this graphic is just meant to illustrate the idea that there's a battle of narratives in this country, and it's as old as the country itself, and even older. And on the left side, that sunny graphic is meant to illustrate a narrative of inclusion, which is a narrative that recognizes our diversity and the strength in that diversity. And I'm going to explain what that means in a minute. And on the right, it's meant to reflect the narrative that Abraham Lincoln was espousing and our current president espouses now about exclusion and how some populations matter more than others. Okay, so as we're trying to navigate health in this country, there are a bunch of background themes that animate our policy conversations. One is income inequality. 2, mass incarceration. 3, our student campus protests. 4, immigrant and refugee crisis in many parts of the world. Black Lives Matter. In North Carolina, there's a movement called Moral Mondays, and it's an attempt to reinvigorate the Poor People's Campaign that Martin Luther King started towards the end of his life. And there are many other themes. We've got Standing Rock, we've got the Chicano movement, we've got immigrants' rights, DACA. There's a whole host of movements in this country today that animate our politics, and there's a theme that runs through many of these movements, and that is exclusion. And that is that some people matter more than other people, and that triggers this need to demand to be seen, which is essentially what these movements are all saying, that we matter, our presence matters, our rights, our opportunities matter. So I mentioned Lincoln and I mentioned our current president. They both espouse the narrative of exclusion, at least in the speech that I quoted to you from Abraham Lincoln. A narrative of exclusion does 3 things, and it does them very intentionally. The first thing it does is it dehumanizes the target. So when our current president announced his campaign for the presidency, he literally called a group of Americans rapists. He said they're bringing drugs, they're bringing crime, they're rapists. Other politicians have talked about makers versus takers, or the 47%, the folks that are so-called dependent on government resources, or welfare queens, super predators, crack babies. Those are all very intentional dehumanizing labels to suggest that this population doesn't belong and doesn't deserve. The second thing a narrative of exclusion does is it exaggerates. Remember, I talked to you about scarcity in that early definition of politics, that I didn't like the notion of scarcity because the narrative of exclusion exaggerates scarcity. And it suggests that there's a limited number of resources and that there's a zero-sum competition for resources between tribes. And the third thing that it does is it looks to the past with nostalgia, make America great again. And it looks to the future with fear. Now in California, we actually have managed to change the narrative. Here we have largely a narrative of inclusion, and the narrative of inclusion does almost the exact opposite of a narrative of exclusion. First thing it does is it changes the narrator, which is a really important point, allowing people, farm workers, undocumented, DACA, formerly incarcerated people, LGBTQ, others, to speak for themselves, to tell their own stories, to allow them to share their humanity with us so we see our commonality in their stories. The second thing it does is it broadens the lens to show how we're all mutually interdependent and that our fates are interconnected. And it highlights the fact that we live in a time and country of abundance. And then third, it looks to the past realistically. It tells the truth about Abraham Lincoln. It tells the truth about slavery and Native American genocide and the Bracero program in California and Chinese exclusion, Japanese internment. It tells the truth about our imperfections, and it strives to move forward in a way that allows us to essentially improve and recognize the strength in our diversity. Okay, so let me tell you about place. You heard that I grew up in Montreal, Canada. These are some scenes from Montreal, Canada. Canada was a wonderful place to grow up in the 1970s and 80s when I grew up there with my two brothers. Wonderful parks and good housing stock and public art and wonderful restaurants and cafes, state-of-the-art public transportation system. This is a view of downtown Montreal with the St. Lawrence River in the background and McGill University in the foreground, where I went to school for free. Canada has a strong social contract. It's got universal health insurance, it's got universal dental care for children, a universal child care benefit for families, paid sick leave and vacation for all employees, good public transportation investments across the country, highly subsidized university and college education. As I said, I went to McGill University for free. In fact, I got paid to go there. I got a scholarship that exceeded my tuition. And it has high quality community resources and community centers, et cetera. Now, this is the second point I want you to take home from this conversation. You can identify the strength of a country's social contract by looking for one word, and that word is universal. And you'll note universal health insurance, universal dental care, universal child care benefit. That universality is a reflection of strong social solidarity across the country. And social solidarity allows us to create universal policies that protect and invest in all of us. Okay, so in the mid-1980s, I left Montreal and I went to Baltimore, Maryland to go to Johns Hopkins Medical School. And I was immediately confronted with this scene. These are images directly across the street from Johns Hopkins Medical School, and both in the 1980s and subsequent to the 1980s. And I go back to Hopkins probably every other year, and things have not changed significantly. And I had never seen anything like this before. And I asked the person who was touring me around, when was there a war here? It looked like a Beirut or a bombed out city. And I'll never forget what he said to me. He looked at me with this look of utter disdain, and he said, "What do you expect? It's the inner city." And I had never seen an inner city before. Montreal doesn't have an inner city. I've since gone to every major Canadian city to look for an inner city. They don't exist. This inner city phenomenon is somewhat of a unique American phenomenon. There are other parts of the world that have barrios and have favelas and have banlieues, suburban areas that are run down. But this core inner city decrepitude is an American phenomenon, and it's a product of racial segregation. Baltimore has some of the most invidious racial segregation record in the history of the United States, but it's not unique to Baltimore. And I asked myself the question, well, what if I had grown up in East Baltimore, like this young man, instead of having grown up in Montreal? Would I have been able to do the things that I had done? Because this kid walks those streets every day, and the message is reflected back to this child that he doesn't matter. And these kids are not stupid. They internalize that message. They understand it. You see it come out oftentimes in rage at a young age. It's not just Baltimore. If you go to a place like South Indiana, which is notorious, some of you may know this. This is Austin, Indiana. It's famous because it had, for a time, the world's highest incidence of HIV/AIDS, higher than sub-Saharan Africa. And Austin, Indiana is 98% white, and it got caught in the grip of an opioid epidemic with a lot of needle sharing and the transmission of HIV and hepatitis C, and an amazing outbreak broke out there. The governor at the time was Mike Pence, who's now the vice president. The health commissioner, who's a friend of mine, Jerome Adams, is now the Surgeon General. And Jerome struggled to get Mike Pence to actually allow for needle exchange in Indiana, to actually head off this epidemic. Finally, he was successful, and they managed to actually get the epidemic under control. My point is that for all intents and purposes, Austin, Indiana, and East Baltimore, Maryland are two sides of the same coin. This is how income inequality manifests itself in black and white in America. And so the question that I have for you to think about, not answer right now, unfortunately, is what is America's social contract or compact? What are the universal policies, the universal investments that the United States makes in all of us? If we had more time, I'd ask you to actually answer that question, and I have a pretty good sense of what you would say. But think about that. So I left Baltimore with this sense of, when it comes to your health in the United States of America, does your zip code matter more than your genetic code? I looked at East Baltimore and I said, there is no way that people living in this community can have a healthy life. There are just too many barriers in their way to health. And it's unfair, and it's unjust, and it's the product of racism. So I tried to prove this using data. I ultimately ended up in California. This is the San Francisco Bay Area. Hopefully you recognize Santa Cruz. It's not quite on the map there. But this is Alameda County, and I became the health officer and subsequently the health director in Alameda County. And when you're the health officer, you're the registrar of all births and deaths. There are about 20,000 births in Alameda County every year, about 10,000 deaths. And you get a death certificate for each one of those deaths, and you can refuse to actually file the death certificate if the data on the death certificate is inadequate. And so I used to say in Alameda County, which was sort of a joke, that you're not dead until I say you're dead, because literally you couldn't dispose of the body until the death certificate was filed. And on a death certificate, you get some really good information. You know what somebody died of, what their age was when they died, their race, ethnicity, and where they lived. And again, with 10,000 deaths every year, you get a lot of new data. So we took roughly 50 years of Alameda County data and we analyzed it. We put it into a massive database, and we started to create some interesting depictions of death in Alameda County. The first thing we did is we took the whole map of Alameda County at the census tract level, and we calculated on average how long somebody could expect to live in their census tract, which is a rough approximation of a neighborhood. And what you see here are those areas in green are census tracts in Alameda County where people can expect to live on average greater than 80 years. In the red, people can only expect to live about 74 years. And those red areas are concentrated in the flatlands of East Oakland, some of West Oakland, and parts of the flatlands of Berkeley. And in the yellow areas, people can expect to live between 73 and 80 years. But these life expectancies are not randomly distributed. You see concentrations of premature death in those red areas. This map got a lot of attention. It ended up on the front page of the San Francisco Chronicle, and many people wanted to understand what was happening in Alameda County, and some even went as far as to say this is only happening in Alameda County. And so we spent a little bit of time trying to show that this was not unique to Alameda County. We took our Alameda County map, and I had to go back to Baltimore to try to understand how this was manifesting itself in Baltimore. And we found neighborhoods in Baltimore with life expectancies on the order of 58 years. We went to Cleveland, found similar phenomena. We went to Denver, to New York City, to Seattle, to Los Angeles, to Minneapolis, St. Paul, to Boston, to Philadelphia, San Antonio, to Chicago. Everywhere we looked, and we looked actually several other places. We're now actually looking internationally at a variety of different cities in Canada, Australia, New Zealand, and Western Europe. But everywhere we looked in the United States, we found neighborhood differences in life expectancy on the order of a minimum of 12 years, but often 15, 20, 25, and in a couple cases 30 years, like in Chicago and Cleveland. And so we didn't find any city anywhere we looked in the United States that didn't have significant life expectancy differences between neighborhoods. This is the American pattern. And we've essentially stratified primarily through segregation, racial segregation, but also income segregation. We've stratified opportunity in our American cities according to neighborhood. And now you can predict any number of things based on somebody's address. You can predict how long they're going to live. You can predict how much money they're going to make. You can predict whether they go to college, just based on one variable, their address. And it's not because we're smart and we're magical witches or something. It's because that's how we stratify opportunity in this country. That's the primary pattern. So this idea of health as genetic or health as transactional or health as behavioral are actually pretty weak explanations for this phenomenon. You cannot explain these differences by any three of those theses. The only thing that explains these differences are differences in political power. It's the only thing that correlates with these differences in life expectancy. So we spend a lot of time in our work basically shouting this from a mountaintop. These are real zip codes in California and real life expectancies. We've done the same thing with high school graduation rates. And one of the things that happens to me when I tell people this stuff is that some people refuse to accept it. They refuse to believe that it's true. And, I've had typically doctors that will come up to me and say, "Hey, Tony, you seem like a very nice guy, but, you're Canadian, so you don't understand America." The truth is America is the most generous and healthy country in the world. The problem is that we have all these immigrants, and we bring in the tired, the poor, the huddled masses, and they bring with them their diseases. And so we take them into our hospitals and we treat them with our drugs and our technology, and we make them healthier. But it takes a while for them to get healthy. So if you really want to see how healthy America is, just look at white people. So I said, okay, let's look at some data. The first thing you want to do is actually get a sort of an overview of some generalized data about American health. And I love Time magazine covers because they tend to sort of really shout out the sort of the scary truth. This one's called The Sorry State of American Health. You've seen this data. This data is well known. This is per person spending on healthcare in the United States compared to other Western countries. The United States is the one on the far left. We spend twice on a per person basis on medical care what most other developed countries spend, and we get relatively poor results as a result of that spending. You may not have seen this graphic, which is a very similar analysis, but it's clever insofar as it does one other thing. So now that blue bar is per person spending on medical care, but added to it is that red bar, which is per person spending on social benefits and social services. So now you see that the United States is actually not the big spender. We spend about the average of other developed countries in the world. Our spending is just sort of inverted. We spend disproportionately on medical care, whereas most of the other developed countries in the world spend disproportionately on social benefits and services. And so this is the interesting thing. We say that, we have the accent on the wrong syllable. We spend mostly on the most expensive part of this spectrum, on medical care services. Well, these two women were the ones that created this graphic by the name of Elizabeth Bradley and Lauren Taylor. It was such an interesting graphic that they published an op-ed in the New York Times. And the New York Times op-ed got so much attention that they converted it into a book. And it's called The American Healthcare Paradox. And then the subtitle is Why Spending More is Getting Us Less. So our spending is not that we spend more, we just spend stupidly. We literally spend on the most expensive part of the system, and we underinvest in that part of the system that actually delivers more health. So they showed that in the OECD countries, those are Western developed countries, for every $1 spent on healthcare, roughly $2 is spent on social services and benefits. And you can see the list of the benefits that they studied: unemployment benefits, housing benefits, family benefits, etc. In the United States, on the right side of this slide, for every dollar we spend on healthcare, we only spend about 55 cents on social services. So we literally have the inverse ratio from the rest of the developed world. This was a controversial study. I mean, so controversial that several scientists decided that they needed to repeat it. And they repeated it with RAND, and RAND is an international kind of social science organization. And so RAND actually replicated Elizabeth Bradley and Lauren Taylor's study because they thought it couldn't possibly be right. It was so compelling that it had to be wrong. So when RAND replicated the study, they found that not only were Taylor and Bradley right, they were actually more right than even they thought they were. And this is out of the RAND study. And I'm just going to walk you through this because I'm not in the room with you. You're looking at a graphic that looks at various different measures from 1980 to 2010, so a 30-year period. And the top line, the top dark orange line, is social spending in the European Union. So this is how much those countries in the European Union from 1980 to 2010, so moving from left to right on the graphic, spend on the social benefits that I described a little earlier. And then look at the dark blue line. That's United States social spending from 1980 to 2010 on social benefits. And you see this gap from 1980 all the way to 2010. The European Union spends significantly more on social benefits than does the United States. The other thing that you need to see on this graphic are the sort of the faded orange and blue lines. The faded orange is life expectancy at birth in the European Union. So look at 1980, and you see where life expectancy is, and then it grows throughout that 30-year period. The light blue line is U.S. life expectancy at birth. And you see that U.S. life expectancy, which is a general measure of health status, is about the same as European Union life expectancy in 1980. And then by 2010, we're significantly further behind the United States, or behind the European Union. Okay, I'm going to go to the next slide, I think. Okay, my computer seems to be frozen for reasons that I don't understand. Oh, there we go. Okay. All right, so this is what the RAND study concluded. I'm going to walk through this fairly quickly. They said higher levels of social spending, so this is on social benefits and social services, are strongly associated with better health. So if you want good health in your country, spend more on social benefits and less on health care. They went on to say that the association is particularly strong for public as opposed to private social spending. That means government spending on social benefits is particularly influential as compared to private benefits. They also said that the association between social spending and health outcomes is strongest where health inequality is greatest. In other words, those countries like the United States, which have a high level of income inequality, social protection actually may be more important for health outcomes in places like the United States. And they further went on to show that even across the 50 states of the United States, the differences hold. In other words, those states that spend more on social benefits have better health than those that don't. Okay, I remember people told me that white people were healthy and that brown and black people were the problem. So I looked at white life expectancy, and it's actually not bad. It's about 79 years in the United States, and it's actually gone down a little bit over the past few years. But it's about the same as Qatar, Costa Rica, and Nauru. But U.S. whites are living shorter lives than people in Belgium, Chile, Denmark, Lebanon, Slovenia, Austria, Finland, Germany, Greece, Ireland, Malta, the Netherlands, Portugal, the UK, Canada, of course, Cyprus, France, Iceland, Israel, South Korea, Luxembourg, Monaco, New Zealand, Norway, Sweden, Andorra, Australia, Italy, San Marino, Singapore, Spain, Switzerland, and Japan. There's 33 countries in the world that have longer life expectancies than the U.S. whites. In 1990, there were only 17. U.S. white life expectancy is actually in free fall compared to the rest of the world. It's so bad that health disparities researchers no longer use whites as a benchmark. We're much better off using immigrant Latinos or immigrant Asians, or quite frankly, immigrant anybody. Immigrants all have better life expectancy and general health status than their American-born peers. And then as they acculturate, their health actually gets worse. If you don't want to believe me, go look up this report that the Institute of Medicine created, a few years back, and they looked at U.S. health compared to other peer countries, and their conclusions were that they were struck by the gravity of their findings. For many years, Americans have been dying at younger ages than people in almost all other high-income countries. This disadvantage has been getting worse for 30 years, especially among women. They go on to say that the U.S. health disadvantage cannot be fully explained by health disparities that exist among people who are uninsured or poor, important as these issues are. Several studies are now suggesting that even advantaged Americans, those who are white, insured, college-educated, and upper income, are in worse health than similar individuals in other countries. That's pretty stunning and not terribly well known. This is the PBS News Hour asking that basic question: why are so many white Americans dying young? This is the Wall Street Journal looking into declines in life expectancy for white women in the United States. And this is a title that I like, Deaths of Despair, which is focused on basically three causes of premature death: drug overdoses, alcohol-related organ disease, and suicides, and seeing that this is disproportionately impacting white Americans. This comes from the work of two Princeton economists, Angus Deaton and Ann Case, who actually published this graphic a few years back. Angus Deaton won the Nobel Prize, not for this work, but for related economic work. And these are mortality rates now from 1990 to 2010, and with mortality rates, you want to see them going down. And so these are multiple different groups looking at their mortality rates, and all you need to look at in this graphic is that dark red line at the top, which is U.S. whites. And you see from 1990 to 2010 an unprecedented increase in death rates amongst U.S. whites. So again, I'm showing you this because there are a lot of assumptions and myths about the health status of Americans. And the reality is that American health is not good across the board. It's not just disparities, it's the health of white Americans as well. And there's an epidemic happening amongst white Americans that is actually larger than the entire U.S. HIV/AIDS epidemic. It's responsible for over 500,000 excess deaths in America, and it's driven by those three causes: drug overdoses, disproportionately opiates, alcohol-related disease, and suicide, all self-inflicted causes of death. Okay, so I'm going to move quickly because I'm beginning to wonder about the time. But the fact is, U.S. life expectancy has decreased for the first time in over 100 years, 3 years in a row. This last year, it actually ticked up a little bit. So 3 out of the past 4 years, you've seen a decrease in U.S. life expectancy, which is really unprecedented, at least in the past 100 years. I mean, it's such a phenomenon that even Sanjay Gupta is doing documentaries on it, and he's getting most of the information right, maybe 70%. Again, this issue of how your zip code shapes your health is something that we spent a lot of time trying to get policymakers to understand. When Sacramento built out its new terminal, we decided we would litter the walls of the new terminal with this messaging, and legislators started calling, asking why we were decreasing property values in their districts. When San Francisco held the American Public Health Association meeting, we covered downtown San Francisco with these posters. Similarly, in San Diego last year for APHA. We're trying to tell this story so people understand that the narrative of health is not just about behavior, medical care, and genes. Okay, so we know 80% of what shapes your health happens outside the doctor's office. That's been documented in study after study after study. In fact, the number is probably closer to 90%. So what is causing people in those red areas to actually have shorter lives? Well, I'm going to simplify a lot of science for you and tell you that this notion of allostatic load is basically chronic stress. We create through policy unnecessary stress in the lives, particularly of low-income people, but quite frankly for all of us. And the fact that you can lose your job and therefore lose your health care simultaneously, as is happening in the COVID crisis, that's a policy issue. That does not happen in most of the developed world. It happens in the United States because we've chosen to create policy in that particular way. So chronic stress is manifest in a whole host of different ways: long commutes, inadequate housing, being socially isolated, being exposed to racism or crime, having so-called low demand or high demand, low control jobs, or lacking access to basic amenities. All of these things are stressors, particularly in the lives of low income people. The way the body interprets stress is through that brain, the hypothalamus, which sends a message to the pituitary gland, that sends a message to the adrenal glands, which release a cascade of hormones, amongst which is cortisol. And in an acute moment, like when my slide started to fail there, we feel stress. Cortisol shoots up in your blood, it stimulates your cardiac output, it rallies glucose from your muscles in case you need to flee or fight, it enhances your immune functions, it turns down inflammation, and it stimulates the growth of neurons in your prefrontal cortex and hippocampus, which are necessary for what's called executive function. Simplifying executive function, it's basically the ability to do immediate triage. It's to figure out what tool to bring to the circumstance that you're facing in that moment. However, people living in those neighborhoods that I described where life expectancy is short are chronically stressed out. They're looking for resources all the time and not finding them. They may have schools that are not functioning. They can't find safe places to recreate. They can't find healthy food. They're having to deal with crime. Even their water may be contaminated with lead or arsenic. And so they're constantly bathed in a fog of chronic stress and have cortisol circulating at high levels 24/7. And when cortisol is circulating 24/7, it does the exact opposite of what it does in the acute phase. And it stimulates directly on your physiology, high blood pressure and heart disease. It causes glucose intolerance and insulin resistance, which are precursors to diabetes type 2. It causes inflammation, turns down your immune system, makes you more prone to infection like COVID-19, and it causes atrophy and death in those neurons, that part of your brain, which is responsible for executive function. So we now recognize that low-income people in this country and high-income people in this country are actually physiologically different. Not because they were born that way, but because we made them that way through policy, or oftentimes it's the absence of policy in the face of abject need, which is what I define as policy violence. It's intentional neglect of need. Okay, I'm coming to the conclusion now. This is a framework that a number of Bay Area health officials put together because we were frustrated that the tools that we had at our disposal in public health were inadequate to the challenges that we were seeing, particularly those around health equity. And so this framework talks about the medical model, which is the sort of three kind of categories of intervention. Starting from the left, you've got risk and risk behaviors, so smoking, the drinking, etc., and you try to intervene in those behaviors by changing what people know and getting in front of the doctor in a 15-minute intervention in a cubicle where the doctor tries to encourage you to adopt healthy behaviors. Those risk factors and risk behaviors increase the likelihood of disease, particularly chronic disease, but also infectious disease. And we try to tinker with people's genes to try to alter the course of disease, generally not very successfully and at great expense. And if people have a higher burden of disease, they're more likely to have premature death. And so that's what the medical model is. That's a $3.7 trillion enterprise. And we think that it's necessary, but not sufficient. And that there are a whole host of upstream opportunities that we ignore that could help us reduce the burden downstream. And these upstream opportunities are basically the social contract. And other countries have figured out how to intervene upstream in ways to head off downstream demand. And so upstream, running from the left to the right, I mentioned, in the Canadian social contract, you have that word universal. Universal comes from having a narrative of inclusion, where everybody is seen as valuable and worthy. And so rather than having a core narrative based on racism or classism or sexism that shapes policy, which is the next box, many other countries recognize that there's a need for shared solidarity. So they have a narrative that talk about themselves as Canadians or as Danish or Swedes. And as a result, they have policies that invest equally across populations, generally early on, in a way that prevents the inevitable illness and despair. And then ultimately in the United States, if you have a discriminatory narrative, which is the first box, which creates policies that discriminate, you end up essentially with social inequities, typically manifest in those maps that I showed you in neighborhoods that are devoid of just the full spectrum of health protective resources that we all need. Note that there's an arrow in here that talks about family and culture. We know that immigrants are somewhat buffered from the impact of low-income communities, but over time, as they acculturate, their health actually gets worse. Okay, I'm concluding soon here. Downstream, we talk about health disparities. Upstream, we talk about health inequities. You can take the word health out and talk about inequities producing disparities. Or if you're simple-minded like me, you talk about conditions producing consequences. We spend an enormous amount of time and money managing consequences in this country. Those consequences can also take the form of educational consequences, as well as health consequences, and a whole host of other domains of human life. The point is that the upstream factors remain the same. And we've simplified in my organization those upstream factors into three things. Narrative. Narrative shapes policy. Policy creates conditions. And those conditions are oftentimes manifest in neighborhoods, not exclusively, but oftentimes manifest in neighborhoods. And we've argued that the solution to this is democracy, is to optimize democracy in these communities and across the state, and to build social, political, and economic power in a critical mass of people so that they can hold local systems, like in Santa Cruz, accountable for equitable outcomes. And that's critical in this work, that we're all accountable, including the California Endowment, including the health department in Santa Cruz County. All of us are accountable for optimizing democracy and allowing people to voice their interests in these political decision-making arenas. Okay, so healthcare costs live downstream, health itself lives upstream. The goal in this game is to move those costs upstream, to turn them from expenditures into investments. I want to conclude on this notion of policy violence. We sometimes act as if, for instance, the fact that we have millions of people uninsured in this country is somehow a natural phenomenon. It is not. It's an intentional phenomenon. We had the opportunity in 1965 to create universal health care. We chose not to, largely because Southern senators filibustered and didn't want blacks to benefit from Medicare and any universal kind of health insurance scheme. As a result, we have Medicare and Medicaid, which is a patchwork, and we have all of these people that fall through the cracks. That's just one example of policy violence. Another one is how we fund school systems in this country, how we fund post-secondary education, and the fact that people have to go into debt to finance just a college degree. That is not true in most other developed countries. It's a uniquely American phenomenon. This is Reverend William Barber, who is reinvigorating the Poor People's Campaign that Martin Luther King started just before he died, and obviously Jesse Jackson there. I wrote an op-ed recently on COVID-19 and how policy violence has essentially created the vulnerability, the social vulnerability that we see manifesting itself now in the death toll in COVID-19. And I want to conclude with this quote from W.E.B. Du Bois, who says, "The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation towards the well-being of the Negro. There have been few other studies or other cases in the history of civilized people where human suffering has been viewed with such peculiar indifference." That was over 100 years ago. Okay, so I'm going to conclude here for time reasons, and hopefully we can have an opportunity to take some questions. So I'm going to stop sharing my screen.
All right. Well, Dr. Iton, please know that we are giving you a round of applause. Thank you for shining the light on these inequities and offering ways that we can move towards a more upstream approach. And what stands out to me is how you spoke about the term universal. But that word alone just captures inclusion, speaks to inclusion, speaks to bringing everyone together, that everyone matters, and how this, in the long run, is a stronger, more healthier benefit for communities and for our country. So thank you. I do have a couple of questions, and I'm sure the HIP team would agree with me if I say, please continue to submit your questions in the chat box, but we will get started. And I'm going to start with a question from Caitlin Brune, who, you know, when you said social solidarity, my mind quickly went to Caitlin's face, because she's one in our community that speaks to social solidarity. Oftentimes, she even made it a hashtag here in our community. And her question to you, Dr. Iton, what are the recommendations for narrative change work at the community level that can help expand or fortify a strong advocacy base that can pressure local decision makers to adopt this perspective, i.e., health policies, that correlation between health and policies that embrace universal protections and goods? And I'm happy to reread that if you need me to.
No, I get it. It's a great question. And I'm going to give a short answer, but there's a much longer answer that, you know, I would be happy to give at another time. And, you know, I think the key thing to remember with narrative, narrative is so important. The reason I start with that Abraham Lincoln slide is because we, particularly folks that are on the progressive side, often skip the narrative part and go immediately to policy, because, you know, progressives tend to be wonky, and we like the sort of the nuts and bolts of policy and the cleverness of policy. Conservatives tend to go immediately to narrative, and they simplify issues. They talk about limited government, they talk about liberty, they talk about, you know, pulling yourself up by the bootstraps and social or individual responsibility. And that, you know, whether you agree or not, it's a clearer message. Once you agree to those values, you're likely to support policy that basically enshrines those values. And so what I think a lot of people don't recognize is that when you're trying to move policy, you're really not talking about the policy. You're talking about the values. And the values, and in this case, I think it was Caitlin, the values that you need to essentially first elevate are values of identity. Who are we as Santa Cruzites? You know, what is it that we believe in? How do we move, you know, in the world? Do we take care of each other? Do we take care of the less fortunate? Do we value our shared humanity? Do we recognize the strength in our diversity? You have to lock down the narrative first before you start talking about policy. And we've done this in California, you know, with a number of different campaigns around the undocumented, formerly incarcerated, LGBTQ, these boys and men of color, these populations are the victims of narratives that are basically narratives of exclusion. So before you can even start talking policy, you've got to shift the narrative. And there are very well documented ways of doing that, which is part of the longer answer. But at its heart, it's about identity, who we are, trying to break up that sort of notion of tribalism and talk about this sort of collective identity that distinguishes and characterizes Santa Cruz and folks that come to Santa Cruz because they believe in those values.
Thank you. Thank you. Our next question comes from Kathy Bell Barlow. Are we listing countries that support universal health care when we are advocating for universal health care for the United States?
Well, Kathy, I think that there's a challenge in the United States, and it's this notion of American exceptionalism. It's like we can't find examples of good policy anywhere in the world because we're so unique. Like I said, I grew up in Canada. It's like literally right across the street from the United States. There's a great example of a universal healthcare system there that is enormously popular. Canada has longer life expectancy than the United States. It has fewer disparities than the United States. Its system is less expensive than the United States. So it's many Americans cross the border to get healthcare and pharmaceuticals in Canada because they're cheaper. So if you don't want to look at Canada, you can look at literally 16, 17, 18 Western European countries that have universal healthcare systems, all with their unique models. But the key is the universality. So I think that if it was a matter of just finding other models in the world and just saying, hey, these guys have figured it out, let's replicate that, this would have been a no-brainer 30 years ago. So it's not about that. It's about the narrative in this country, and it's about the hostility, quite frankly, to the idea of universality. And as long as that hostility persists, you look at the current president. They're interested in dismantling the Affordable Care Act in the midst of an epidemic, a pandemic, which is causing people to lose work and losing health insurance. So that's not logical. That's about a narrative about who matters and who doesn't matter. And until we can address that narrative, which we can, because we've done it in California, not completely, but we've moved the narrative around these kinds of policies to one of inclusion. Until we can address that narrative, just looking at other countries is insufficient for changing policy in this country.
Okay. Thank you. We have 3 minutes to go and 2 more questions. So I'm going to start with Anita Aguirre, and please excuse me if I mispronounced your name. Charge it to my head, not my heart. How do we use our current experience during COVID-19 to immediately inform and advocate for policy change? For example, housing standards and access, etc.
Okay, am I muted? Okay. You want to ask the other question too, and I'll try to get at that, both of them?
Okay, so how do we use our current experience to inform and advocate for policy change? And the next question from Marion Broadkeep. Oh, something's moving. Okay, universal is used in a manipulative way when talking about health insurance, which is also called health care, quite dishonestly. Would for all be a better use of language when talking about social services, health care, and other determinants of health?
Yeah, so both of those questions I can try to answer simultaneously, and thank you for both of them. So in this moment, and I think that this moment, COVID moment, which is not, it is going to last for a while. This is not a short moment. We're going to be in this pandemic for probably a couple of years at a minimum. But many of us have likened this moment to post-World War II Europe or the Depression in the United States. And what it does is it creates, because of the shared trauma and vulnerability that has happened across the society, it opens a policy window for essentially policies built around shared solidarity. So you had the New Deal come out of the Depression. Europe built and refined most of its universal healthcare and labor policies post-World War II after the horrific campaigns of bombing that people experienced and the deaths and the Holocaust. And in the United States, which didn't get bombed in World War II, we went a slightly different direction, which was basically celebrating our industrial might. But this is a moment in the United States where we're experiencing shared vulnerability. And so what we've been working on in California, even before COVID-19, is, and this sort of addresses the second question, is this notion of a California for all, which is a rewoven social contract in California that recognizes our interconnectedness and interdependence and focuses on investing in Californians with an eye towards heading off some of the inevitable downstream consequences in the future. So in this moment, and a number of us are working together with groups across the state to create a new social contract and this sort of understanding of what a California for all would look like. The governor has embraced the for all messaging that has, that we've developed. And there's actually a document called California for All that 70 different organizations across the state of California have been involved in creating. And prior to COVID, we're planning on doing actually town hall meetings in all across the state. And now that plan has actually had to be revised to figure out how to socialize this California for All new social contract idea across California. If you want information about that, I can send that to the organizers of this conference. But thanks for both of those two questions, because they both tie in together about this need in California and I think a desire to create a movement for a rewoven social contract, and it just happens to be called California for All.
Thank you so much. And more questions have come in, but we do need to move forward with our program. Perhaps, Dr. Iton, there's a way we can give you these questions, because there are a few more that are quite good. We'd love to hear your response to them, especially as we're talking about wellness check, or well child visits and things like that. So we'll send these remaining questions to you, and hopefully there'll be time. Maybe we can answer them today, or maybe we can answer them at a later time and make sure we respond back to this group. So thank you, Dr. Iton. Thank you so much. We are going to transition into our ceremony here. Our lifetime game changer recognition. Woo! I'm sorry, guys, I can't help it. Yeah. We are so thrilled and fortunate to have had Michael Milward in our community. It's interesting, Michael and I both came into this community at the same time back in 2012, and We first met at the Leadership Santa Cruz. And so we both discovered that we were transplants here from other communities. And there was a part of the leadership, I don't want to spoil it if you haven't signed up for leadership, but there was a part that involved redwoods, zip lining, you know the story. I had my reservations about zipping through the redwoods. And again, talking to Michael, learning about his background, being a chaplain, coming to serve as the CEO for Hospice, I thought that I could share my anxiety with him and that he would, be compassionate and feel for me. Well, in the midst of me sharing how I had some reservations about zipline, and he said, the best thing to do is just to do it. And he gently shoved me, and there I go, ziplining and screaming through the redwoods. So, but it speaks to him as a leader that sometimes you just got to go out there and do it. You got to jump. And I'm so glad, because that set the tone to you can be afraid, but don't be paralyzed by your fear. Don't be paralyzed by your current situation. And that again just speaks to Michael and his leadership style, that he has done everything graciously. I want to remind this group that Michael will be having a virtual farewell ceremony. So Zoom that, people. Let's make sure that we join this virtual ceremony later on this afternoon at 4 o'clock. Each of you will receive a link to sign up for this virtual party. It will appear in the chat box. Then at this time, I'd like to turn the mic over to our County Supervisor, John Leopold. He's on the line.
Thank you, Keisha, and it's great to be able to join everybody. If we can't all see each other, it's great to be in communion together through this interface. I want to just take this opportunity, first of all, just to thank all of you who are involved with healthcare for the role that you have played over the last couple of months. Santa Cruz County has benefited from the ongoing institution that is the Health Improvement Partnership, because we are a collaborative community. And when this COVID-19 pandemic hit our community, we use that collaboration in order to best meet the needs of the community. And it's great to see people recognizing healthcare as a priority issue and those in healthcare as heroes. Those of us who've been working at it know that this is what we should be talking about all the time. And if we did it, it would really help address so many other issues that we have, as the keynote speakers said today. But I want to thank the Health Improvement Partnership and all of you in healthcare for your ongoing work. I do want to recognize Mike here today with this Lifetime Game Changer recognition. Mike has done incredible work over the last 8 years with Hospice of Santa Cruz County. He's played an incredibly important role, not only in the ongoing work of the agency, but also in forming collaboratives with other organizations to strengthen and help grow nonprofit palliative care coalitions. He's served in a national role and helped others. And he is just a joy to be with. He's a joy to the staff, the donors, those in the community. And I wish we were all there to shake his hand and hug him, because he doesn't deserve just a Zoom retirement party. He maybe deserves a parade. And so I have a proclamation here today to share with Michael, and I just wanted to share part of it with you, and I hope you will join me. Whereas since 2012, Michael Milward is committed to serving individuals in Santa Cruz County experiencing serious illness and facing the end of their lives by bringing compassion, creativity, and profound commitment to dignity, equity, and quality in care. And whereas during his tenure as CEO of Hospice Santa Cruz County, Mike enriched Hospice Santa Cruz County's program with the launch of a palliative care program, concurrent care services for children, Camp Aaron, a bereavement camp for children, initiation of pet companion and music therapy programs, and bilingual programming for children and families. And so now, therefore, I, John Leopold, 1st District Santa Cruz County Supervisor, but on behalf of the entire Board of Supervisors, want to thank, honor, and commend Mike Milward for his heartfelt commitment to supporting the mental, physical, and spiritual well-being of the hospice team and the people and families in the counties served by Hospice Santa Cruz County. Thank you for your work, and let's all recognize the great contribution that Mike has made to Santa Cruz County.
Well, John and Keisha and everybody, thank you very much. I am honored to receive this award from HIP, an organization I have such respect for. This is truly special. And I gratefully accept this recognition as exactly that, a recognizing of the remarkable people that I am lucky enough to work with at Hospice in Santa Cruz County. And this award also shines a light on the work that we are so fortunate to be able to do. And I thank you for that as well. I am reminded that this morning a number of people in our community woke up for the last time. They are our family, our friends, our neighbors, and it is our job to help them. As we speak, our folks are at the bedside providing compassionate care and, importantly, bearing witness to what are surely precious days. We are privileged to be invited into what I have referred to since my days at the bedside as a hospice chaplain as the really real, circumstances of remarkable poignancy and intimacy. And in this time of COVID, our work is even more complex for our patients and families, for those who are grieving, and for our staff. And I think this is a time when our work is even more relevant, and I think that's true for all of us. Here in Santa Cruz County and across the country, perhaps never before has the larger culture felt such fragility, uncertainty, indeed our mortality. Conversations around our healthcare choices have never been so important or time urgent. Physicians and really all of us in healthcare are engaging in conversations around advanced illness and death and dying as never before. With hospital and particularly ICU beds in potentially short supply, the medical community has been revisiting how we can keep seriously ill and terminally ill folks home, how we can palliate their symptoms in an environment that's actually better for the patient and for the system. For some years now, our work has called us into the world of population health around serious and advanced illness. The wraparound care that the hospice model is so good at is incredibly effective and much needed in the years before death, not just the months, weeks, and days that heretofore has comprised most of our work. We know that healthcare navigation, home-based palliative, and even home-based primary care that includes important psychosocial support helps to keep patients at home and improves the quality of their lives. A healthy community where people want to live, rear their families, and eventually leave the world necessarily includes a quality hospice. And while we have seen hospice move from a radical notion in the 70s to a more widely accepted care option, we know we still have work to do. Hospice still remains for many frightening and misunderstood. Nationwide, somewhere between 1/3 and 40% of hospice patients come to hospice with less than 7 days to live. We hope for the day when we no longer hear a family member tell us that if they had understood just how much hospice could help, that they would have called us sooner. And of course, a healthy community is also the North Star for the Health Improvement Partnership. It has been my privilege to have been a part of the HIP community for the past 8 years, and I can assure you that we at Hospice of Santa Cruz County deeply value our seat at the HIP table. Mother Teresa once described the world's ills this way. She said that we have forgotten that we belong to each other. Ram Dass said it this way: we are all walking each other home. One need only to listen to Dr. Iton's remarks this afternoon to understand how deeply the HIP community understands the observations of both Mother Teresa and Ram Dass. I have been inspired by the courage, compassion, and perseverance of my colleagues at the HIP table. This is a community of people that imagines a circle of compassion and then imagines that no one is left standing outside that circle. This is a community of leaders who collectively move toward the margins so that the day may come when the margins themselves will be erased. In the Christian scriptures, specifically within the narrative world of Matthew's gospel, we find the Beatitudes, words of wisdom widely regarded in the collection of the world's great spiritual literature. They are readily familiar, and I will paraphrase. Blessed are the peacemakers. Blessed are the poor in spirit. Blessed are those who long and thirst for justice. Blessed are the meek and those who mourn. Interestingly, scripture scholars contend that the original Greek is not precisely translated as blessed are, but instead is more accurately translated as you are in the right place if, as in you are in the right place if you are single-hearted or work for peace. You are in the right place if you thirst and long for justice. Who knew that the Beatitudes are not so much a spirituality, but a geography? They tell us where to stand and what to stand for, where to locate ourselves as we remember that we belong to each other as we walk each other home. My colleagues at the HIP table were surely standing in the right place when they fought relentlessly for access for thousands of uninsured kids, when they courageously dove headlong into the opioid epidemic and created Safe RX Santa Cruz. You are in the right place when you fight every day to provide dental care to thousands in our community who otherwise could not afford the same. You are surely standing in the right place when you locate yourself with the homeless and all those who have been left behind. To HIP's credit, its history of leaning in, of knowing where to stand and what to stand for is extensive. I will close with this. There is a well-known African proverb that states, I am because we are, meaning that it is the collective, the community that is of vital importance. This has been my experience at Hospice of Santa Cruz County and my experience as a part of the larger HIP community. My chance to make a contribution to both has been the privilege of my life. I thank all of you for that and, of course, for this honor. And now, the fun part of the meeting when we get to give away the raffle prizes. We have been receiving pledge themes throughout Dr. Iton's remarks, and they are really remarkable. They are all a whole bunch of action verbs, people pledging to strive for social justice, to talk about connections, to give voice, to advocate, to serve, to engage, to collaborate, to listen, to change. These themes are inspiring, and we thank everyone for all of your pledges. Now, if I can find the right paper, I'm going to read our winners. Here we are. So the first prize goes to Kay Blackwolf. This is the $50 Manuel's Mexican Restaurant gift card. Kay comes to us from the AMR organization. And we are delighted that students joined us today. Our second winner is a student from CSU MD, Shannon Mortella. She wins a $10 Cat and Cloud coffee gift card with Elisa Arona, the local celebrity, the HIP executive director. So congratulations, Shannon. Craig Murray is the third winner from the Santa Cruz Health Services Agency. This is the new patient package at Action Chiropractic. Congratulations, Craig.
All right.
Another student, Maria Diaz from CSUMB, wins the coffee session with Keisha Browder, the United Way CEO, sitting to my right.
Woohoo! We're gonna have fun. Woo!
And Emily Solik from Salud wins the acupuncture session. So those were our 5 raffle winners. Congratulations, everybody.
All right. Woo! Ladies and gentlemen, friends and family, this concludes our annual Health Improvement Partnership Community Forum. I'd like to thank the incredible team and staff at HIP, led by such an extraordinary leader, Elisa Rona. Thank you all for your participation, and we will see you in the community, safely social distancing.